name is Marion Pitters, and I'm delighted to be the facilitator for today's webinar. I'm here to introduce our expert speakers, moderate some questions from you, our audience participants, and ensure that the webinars progress according to the schedule so that we respect everyone's time. But first, on behalf of McMaster University, it is my pleasure to welcome you to the 6th webinar of the 10-part series, Expert Perspectives on Pandemics. We have participants from all over Ontario, Canada, and the globe online today, graduate students, faculty from McMaster and partner institutions, as well as representatives from the Pan American Health Organization, PAHO, the World Health Organization, WHO, and some new invitees are with us for the first time. Many of you are preparing to contribute your skills to mitigation of the COVID-19 pandemic. We welcome you all to today's compelling session. The COVID-19 emergency presents a global challenge to our healthcare systems, our economy, and our ways of living. In the face of this unprecedented global health crisis, McMaster is dedicated to innovation and collaboration in the discovery of solutions to help combat COVID-19. This series is integral to the Master of Science in Global Health. Experts will delve into topics including historical trends, vaccine development, the threat of antibiotic resistance, and Canada's research response to COVID-19. A quick overview of the 10 webinars in our series can be found at the link where you register, globalhealth.mcmaster.ca/2020 webinar series. At that same link, you can access recordings of the 5 previous webinars. Today's session is Webinar 6, Flattening the Curve of COVID-19, Countries-Specific Comparison. It features Dr. Kurmi, Research Analyst, Department of Medicine, McMaster University, and students from a group that's been working together on the COVID-19 project. A final housekeeping note before we start. Time has been built in for questions and discussions at the end of the webinar. Please use the chat tool to submit questions electronically. And note that while we may not be able to get to all of your questions, our speakers will aim to address them afterwards on the Global Health website. At this point, I would like to introduce Dr. Andrea Baumann. Andrea is the Associate Vice President of Global Health, Faculty of Health Sciences at McMaster University, Director of the Master of Science in Global Health Program, and the Director of the World Health Organization, WHO Collaborating Center in Primary Care and Health Human Resources. Andrea, will you start us off with a few words about launching this webinar series? So, Andrea, if you could unmute yourself.
Thank you, Marion. I must say it's been a pleasure to host this series, and I'm also acknowledging the support of Dr. O'Byrne on the series, and he sends his welcome to both those that have followed the last 5 and are now starting the next 5. It's a pleasure to be able to listen to the various different perspectives. And today I indeed welcome our 2 medical students to join Dr. Kurmi, which is nice to see the transdisciplinary input on this very complex topic. So without further ado, I will pass it back over to you, Marion.
Thanks, Dr. Baumann. Before I introduce our speakers, a quick reminder to post your questions during the presentation in the chat box. Now on to our speakers. Dr. Kurmi is an assistant professor and by training a respiratory epidemiologist. Currently works in the Department of Medicine, McMaster University, and is also an associate member of the Department of Health Research Methods, Evidence, and Impact. Previously, he worked as a senior scientist at the Newfield Department of Population Health at Oxford University in the UK. Dr. Kurmi enjoys playing badminton Originally from Nepal, he's an avid walker. He was attracted to McMaster because of the potential for walking up Hamilton's Mountain, which at 208 meters high could be quite comparable to Everest's 8,800 meters high, according to some Hamiltonians. Enrico Rullo is a first-year medical student at McMaster University. Prior to this, he received both a Master's of Business Administration and a Bachelor of Science at McMaster. When not studying, Enrico's kinesthetic sense and dexterity take over. He has taught himself to play mandolin and accordion and also competed on McMaster's water polo team for 4 years. Kyrillos Faragalla is a second-year medical student at McMaster University with an interest in pathology or internal medicine as potential careers. Outside of his academic studies, Kyrillos likes to play table tennis and read and debate philosophy, hopefully not all at the same time. Dr. Kurmi, Enrico, and Kyrillos, we look forward to your team's perspectives on flattening the curve on COVID-19, country-specific comparison, for the next 35 minutes. I'll provide you with a reminder at the 30-minute mark, and then we'll invite you to engage our global participants in a Q&A session for 15 minutes. Over to you now, Om.
Many thanks, Marian, for the kind introduction, and also to Dr. Bowman for inviting me to be part of this important webinar series on the current COVID-19 pandemic. Hello, good afternoon, everyone. I'll be presenting with Enrico and Kyrillos today. Over the last 6 to 8 weeks, let me change this. Over the last 6 to 8 weeks, April, Jinjin, Kyrillos, and Enrico has been studying on the impact of public health intervention on flattening the curve in different regions of the world. This talk is based on their work, and therefore I think it is important for you all to hear it from them on their findings on this subject. Before I start my talk, I would also like to take this opportunity to thank them all for their hard work. Over the next 30 minutes, I'll start with setting the scene for today's talk and provide you some general background. After me, Enrico is going to talk about the major adverse impact of COVID-19 on general human health, and also we will talk about the economy as well. He will explain the reason why we choose to do this study and then dive into the methods we used. Following Enrico's talk, Kyrillos is going to take you over through the findings for selected countries or regions and any inference that we drew based on our observation. And as Marian said, at the end of our presentation, we are happy to answer any queries that you might have. I'm going to start the presentation by showing you some photographs. All these photographs were taken by various individuals. The name of the photographers and the place where they were taken are mentioned in each photograph. Each photograph tells you a story more powerful than I can describe in words. The first photograph you see here was taken by Enrico at the deserted street of Athens, Greece. I'm pretty sure that this does not need any explanation on how big impact the COVID-19 is having on us. I'm also sure that this is representative of all the major big or small cities across the globe. The second photograph is of a beach in Brazil and again tells another sad story of restriction on travel and leisure. I do not think any one of us would have imagined the desertification of beach, particularly when the weather is so good. When you read or watch the impact of COVID-19 on the poor living in low, middle, or high-income countries, they are the most severely affected with no job and very limited or no resources to meet their basic needs like food. Many of their only hopes of survival is mainly the relief materials distributed by their respective governments or also voluntary organizations or individuals in personal capacity. In high-income countries, The other group very badly affected are those living in long-term healthcare facilities. They are the most vulnerable group with number of co or multi-morbidities, and at the same time, their care or support has been reduced significantly. This photograph was taken when a person in Jordan was waiting for relief material to support him or his family. This is again representative of many individuals living in the lowest rung of the socioeconomic ladder. When we look behind us at our academic institutions, the classroom and libraries are empty. The Global Health Unit at McMaster University, which is organizing this webinar, has an excellent award-winning Master in Global Health programs with number of partner institutes, including Maastricht University in the Netherlands. This year, over 300 students and faculty from all their partner institutes were supposed to visit Manipal in India for 2 weeks. A number of group activities, field visits, and a symposium was planned there, and students and faculties and myself as well was looking forward to this event. But this year, they had to cancel this event in India because of the COVID-19 and organized a virtual symposium. Thanks to the digital world that we can communicate with each other, carry out our teaching activities, organize symposium, or also meet online. But please spare a moment for many millions who are less fortunate than me or yourself, who do not have this option. Since in the midst of the COVID-19 pandemic, the million-dollar question is, when are all these current restrictions going to end? Many are worried whether we'll be able to go back to normal and do activities that we enjoy and love to do. To be honest, I do not know that answer for sure. But what I know that we all are thinking hard on our future activities, our roles and responsibilities to make sure we try to fix the puzzle for a better world. We all know that the recent crisis is the result of the novel coronavirus, which was first reported in Wuhan, China. Although we knew very little about this new coronavirus before it infected human beings. But over the last 4 months, we have developed a better understanding about the virus, its transmission mode from one individual to another, the major symptoms in infected individuals, and at the same time have learned about number of preventive measures. Enrico and Kyrillos will be talking about these measures in detail during their presentation. Nowadays, many scientists across the world are joining hands and working very hard in close collaboration to develop vaccines to prevent the COVID-19, and at the same time trying to find therapeutic measures for those who get the infection. This slide shows you the timeline of the COVID-19 from when it was first reported to the declaration of pandemic by WHO. On 31st December, China alerted the WHO about a cluster of atypical pneumonia cases from Wuhan. The very next day, that is on 1st of January, WHO set up an incident management support team, and on 7th January, identified it a novel coronavirus. On January 13th, WHO reported first case outside China, that is in Thailand. On 30th January, WHO declared its public health emergency, and on the next day, that is on January 31st, first cases were reported in many other countries, including Russia, Spain, Sweden, and UK. And on March 11th, WHO declared its pandemic. This slide shows you the time period and mortality of some of major epidemics or pandemics, with the most recent ones such as Ebola, MERS, and swine flu occurring within the last decade. So far, over 250,000 people with positive tests for COVID-19 have died, and this number continues to increase substantially every day. While we speak now this week, I have been hearing through media reports of major African swine flu occurring in Assam states of India as well. During the early period, many compared it with seasonal flu. However, many researchers over the last 4 months have reported some clear distinction between the seasonal flu and COVID-19. The base reproduction number, the incubation time, the hospitalization rate, and case fatality rate, or more likely the hospital case fatality rate, are higher in COVID-19 compared to seasonal flu. Here, I also think it would be important to highlight that recent community-based data from many countries, including USA, Italy, the Netherlands, Germany, and many more, suggests that the infection rate is much higher in the community than initially thought of, and around 80% of these are either asymptomatic or have mild symptoms. The diagram shows you the case fatality rate with other major epidemics. The y-axis represents the case fatality rate, which is plotted against the base reproduction number in x-axis. Compared to many other recent outbreaks such as SARS, MERS, Ebola, currently available data suggests that the case fatality rate is lower in COVID-19 but slightly higher than the seasonal flu. Following increase in number of epidemics and or pandemics in the last few decades, a global health security index was developed to assess the country's preparedness for infectious disease. This is the first comprehensive assessment and benchmarking of health and related capabilities across 195 countries. It assesses the nation's preparedness across number of health security and improvement in international capacity to address infectious disease outbreaks that can lead to epidemic or pandemic. The expert group first meeting was held in April 2017 in London, and within 2.5 years of the first meeting, a GHS, that is Global Health Security Index, was developed and launched in October 2019. The Global Health Security Index was developed with information obtained from 140 GHS index questionnaires. They were organized into 6 different categories, which are listed here. Number 1, the prevention. Number 2 is the detection and reporting capabilities of different countries. Number 3 is the rapid response of each country or the health system. 5th, the compliance with the international norms, and the last is the risk assessment. Based on the GHS index, a country can have a score ranging from 0 to 100. All the 195 countries are grouped into mainly 3 groups depending on their GHS index score. Those countries with a score from 66.7 and above up to 100 are grouped in the most prepared group. This group has 13 countries where USA tops the list with the highest score, followed by UK, the Netherlands, Australia, Canada, the 5th, and so on. Those countries with a score from 33.4 to 66.6 falls in the most prepared group. There are 109 countries in this group represented by the orange color in this figure. The third group, that is the least prepared group, includes countries with a score in the range of 0 to 33.3. There are 73 countries in this group, and as you see in the figure, it is dominated by sub-Saharan African countries. I would leave it up to you to judge on how well each country did, because there are different reports from different countries regarding the current pandemic, and also think of if there is a need to revisit or reassess the GHS index based on their response to the current pandemic. This graph here shows you the case fatality on day 40 from the first case reported in selected countries, plotted in the y-axis against Global Health Security Index in the x-axis. This graph does show you a clear pattern that those countries with higher GHS index score did better when you look at the first 40 days from the first case reported, that is during the early period. Here you see certain countries like USA, Canada, Germany has no case fatality in the first 40 days. But when you plot current case fatality in the y-axis versus the GHS index score in the x-axis, you do not see that pattern anymore, or there is no any clear pattern. This could reflect the GHS index is less likely to hold true when the epidemic or pandemic is as big like the current one, or it could be some other reason as well. It might be useful to revisit the GHS index. This pandemic also provides an opportunity for all the countries to test the GHS index at different threshold level and fix any existing loopholes if there exist any. Now with this, I would like to hand over to Enrico, who is going to take you through the next round of presentation on this topic. Enrico, over to you.
Thank you, Dr. Kurmi. So there's been both physical and mental health impacts from the coronavirus 19 pandemic. In terms of the hardest hit countries by fatality, we have the United States, the UK, Spain, Italy, and France. So the health impacts of this disease have not been limited just to illness or mortality, however. We've also noticed a number of delayed surgeries, delayed access to care, as well as domestic and substance abuse that has come along with general mental health suffering. On the economic side of things, we've seen massive job and GDP loss, as well as hindered wage growth and decreased credit available for starting new projects and opening new businesses. And it's important to note that these are impacts we will see years after the pandemic ends. Here we see a picture excerpted from Johns Hopkins, their coronavirus tracker. It allows us to look at the incidence of coronavirus across the world. So initially, Asia was the epicenter of the pandemic, but since then, it has moved to Europe and North America, where the curves have begun to flatten in Asia. The curves have begun to flatten in many parts of North America and Europe as well, most notably for us in Canada. As of May 4th, total number of sick has numbered over 3.5 million, and the total number who have succumbed to the disease over 250,000. And this highlights why it's important for us to stay vigilant and stay diligent with adhering to advice from our social and health officers. So taking a closer look at the physical impacts in Canada, we see over 3,500 deaths in 56,000 cases. And the picture on the left shows us that the curve has indeed been flattening. On the right side, we start to take a look at some of the other health impacts, such as the delayed surgeries. As of now, we have a total of 52,000 delays, and it's estimated by the end of the pandemic, we'll have 100,000 total across Canada. So this represents a significant backlog of people who can't get the access to care they need, and as well a significant backlog for healthcare practitioners to deal with once the pandemic comes to conclusion. It's worth noting that in the majority of cases, this has been to no great effect. However, it is estimated up to 35 Ontarians alone have died as a result of their delayed surgery. And this is something that will have to be investigated further after the pandemic comes to conclusion. In terms of delay of care, there's also been less people going in to see physicians, such as in the emergency room. A study by the American College of Cardiology saw the serious number of heart attack interventions in the US dropped 38% from this point last year. They figured it was probably not due to people having less heart attacks, but rather ignoring the symptoms or suffering through them at home. And indeed, a study in New York found that in the first 5 days of April, 1,100 people were pronounced dead at home or in the streets in New York City, an 8 times increase from last year. So in terms of mental health impacts, we see that domestic abuse, for one, has gone up around the world. Canada has increased about 22%, 25% in the UK, and nearly tripled in China. We've also seen alcohol use increase in both Canada and the UK by 18 and 22% respectively, and then cannabis use has been up by 6% in Canada. For China and the UK, data on these other two substances is not available. The picture on the left just highlights the point that domestic abuse has increased around the world, as everywhere from Argentina to Singapore, we've seen increases from about 20 to 30%. The picture on the right shows us that substance abuse has also been increased rapidly in our neighbor, the United States, one of the countries hit most hard by the pandemic as well. So now in terms of economic impacts, we see for job loss, Canada has lost over 1 million jobs alone in just March, and the GDP has shrunk by about 2.6%. These changes are mimicked in the world around us. Worldwide job loss right now is at about 20 million, and this is split between all countries. However, it's projected that depending on how we handle the pandemic, it could rise up to 195 million. And something else worth noting is that although greater job loss has happened in the richer countries, the lower socioeconomic status countries suffer disproportionately more as any job loss represents a greater piece of the pie, as there are less jobs to be had there to begin with. So it's definitely a serious consideration for us and both for political bodies to try and rectify this issue. And again, most major economies around the world will notice at least a GDP loss of 3%. And depending on the way we manage these issues, it depends on how long it affects, rather, how long the recovery will be in the years after the pandemic. So now this brings us as to why we need to flatten the curve. So the dotted line here shows us the healthcare system capacity. So this is a factor of things such as acute care beds, ventilators, the amount of doctors and nurses per capita. And when we exceed this capacity, the number of deaths from cases of coronavirus 19 will increase rapidly. So we need to keep basically the load from this pandemic underneath that dotted line. And as well, by flattening the curve, it gives our government and hospitals more time to increase capacity. So again, by increasing the amount of beds and ventilators and healthcare practitioners. So the ultimate goal of all this is to keep the R0, which is the rate at which the virus propagates, to at or less than 1, as this prevents it from growing. So now we're going to take a little bit of a look at why perhaps the coronavirus pandemic took hold the way that it did. Now, before diving in deeper here, it's worth noting that these major players made the best decisions that they could with the information they had at the time, and hindsight is always 20/20. However, it is worth noting into what possibly could have been done better, as there will be future instances of pandemics that we can use these to respond better. So for Canada, there was some government indecision over which were the best interventions to use. Particularly closing borders was the subject of scrutiny. Our health officers did not know if it would be effective, and also there was debate as to whether the virus would take hold or hit Canada the way that it managed to. As well, few returning travelers ended up being assessed for the virus. There was about 18,000 Canadians that were repatriated from China at the time, and many of them from Hubei province where Wuhan was located. And many were given the option to self-quarantine, and many people did not adhere to that advice. Moving on to the United States, we see that many states are reluctant to declare social distancing, and even now they are opening up against medical advice, some deemed prematurely. And this again could be a possible reason for future outbreaks. And as for the WHO, they initially opposed travel bans, which added some confusion to the debate. And there were also issues with getting funding to countries that needed it for PPE and other such factors. Resistance is another reason why the virus may have taken hold the way it does. So it's one thing for governments to overcome political inertia to pass these laws. However, it's quite another for people to adhere to them. In the picture on the right, we see closed trails and parks, and many people do not leave these areas like they're supposed to, and instead continue to gather in them. And this is also reflected by the protests we've seen in front of Queen's Park. Many people are unhappy with these laws and have not adhered to them, and this keeps the virus propagating. And the picture on the left, again, we see people flaunting social distancing. This is taken from a picture in Kingston during St. Patrick's Day, where people do not appear to be maintaining their 6-foot distance. So all this takes us as to why we did the study. The probability of a pandemic happening in the next 15 years that will kill 30 million people is deemed reasonable. So because of this, it's important that we improve our readiness and response time. The Global Health Security Index that Dr. Kurmi mentioned, its express purpose for being created was to help countries improve their response to pandemics. And we figured that we would help to contribute to this as well. In terms of our objectives, we wanted to compare and contrast our public health interventions in different countries, analyzing the timing of these interventions, and as well to determine what works. So now looking into some of the countries that we chose and why we chose them. We looked for basically 4 criteria to choose countries. One, we wanted an adequate number of countries to allow recognition of qualitative patterns, such as response interventions. Secondly, we wanted to focus on countries that were most affected by the pandemic. Third, we focused on countries that have transparent reporting to be able to collect the data we need. And finally, the language of the country was a factor. We had limited access to their news outlets, and some non-English speaking countries, however, were chosen because of group members who spoke the language. So ultimately, we decided on a total of 12 countries. From North America, we chose Canada and the US. From Europe, we chose Spain, Italy, Germany, England, and France. From Asia, we chose China, Iran, South Korea, and then rounded it out with South Africa and Australia. So looking at the public health interventions, there was basically 2 categories. One was social distancing measures, and this includes things such as stay-at-home orders, factory closures, school closures, curfews, and restricted access in public areas. Some other initiatives were things like government funding for PPE or other medical equipment generation, research studies, as well as some things such as telemedicine, which was another highly impacted order. There are countries like Canada and the US who had greater variability in state or province response. So basically, some states did one thing and some did another. So we tracked if and when at least 75% of the country by population was under an order before we determined that it was given. So in terms of data collection, we mainly use the Johns Hopkins database for the number of cases and deaths, and we also use Our World in Data, which tracks the testing numbers. For information on public health interventions, we relied on government websites and major news outlets in each country. And of course, we couldn't have done it without the help of Google Translate. So now for a look at reproduction number, this is one of the most critical aspects of any virus because it tells us how fast it spreads. For coronavirus, the R0 was determined to be between 2 and 3. So we can see here in the diagram that each person in red has the coronavirus that gets spread to about 2 or 3, and this is the way that it propagates. So just a quick note on R0 versus R values. R0 basically assumes that the whole population is susceptible, which may be true initially in a pandemic. However, in real life, some people may already be immune or develop immunity after contracting the disease. Therefore, R will be changing every day depending on these circumstances, but regardless, we need to get 2 or below 1 in order to see a decrease in the incidence of cases. So now for a look at the results, I'll hand you over to my colleague Kyrillos.
Thank you, Enrico. So I will be taking you through the major findings of our study. In terms of social distancing measures, we found that most countries gave a national stay-at-home order and also closed their schools at some point during the pandemic. In certain places, like South Korea, students were already on a vacation at the time when things started, so they were simply told not to return to school. With the exception of South Korea and France, most countries also closed non-essential businesses. There was, of course, a large variation in what was considered non-essential. For example, believe it or not, pastry shops in France and gun shops in the United States were deemed as essential services. 7 out of 12 countries closed their international borders as well. Other countries placed restrictions on specific flights from high-risk countries like Iran and Italy, as well as additional airport security and screening. We found that only Iran implemented a semi-curfew, and it is actually unclear from the news reports how long this lasted. However, there was more variability in implementing additional initiatives. We found that almost all countries, except Spain, were conducting clinical trials related to COVID-19 that were registered in NCBI. 9 out of 12 countries had centralized contact tracing by a public health agency or its equivalent. 8 out of the 12 countries provided incentives for local manufacturers to produce medical equipment in the form of subsidies or other financial supports. And finally, 5 out of 12 countries only had a self-assessment tool that was available for citizens to use, which is not ideal because it would increase the load on the healthcare system when people with minor symptoms seek reassurance in the emergency department, for example. So next we compare how the reproduction number responded to these interventions, as well as the number of tests conducted in countries with similar GDP per capita and similar WHO healthcare indices. The first group that we look at is Germany, the United Kingdom, and France, which all have a GDP per capita of 40 to 45,000 per citizen, and the healthcare index above 0.9, indicating similar quality of healthcare in these countries. The R curves in these countries started out with a high R value, and eventually, in all countries, they were able to bring it down below 1, and they all did so around day 70 since their first case, respectively. By far, Germany conducted more tests than both of the other countries, and they did so early on in the pandemic, around day 42, as well as more recently in mid-April. Looking at the time when they implemented their social distancing measures, you can see that they were all roughly between 45 and 55 days after their first case. One key difference is noticeable in the time of international border closures, where France actually closed their borders late, around day 70, and the UK is still accepting international flights, but obviously with more airport restrictions. Next, we look at Spain and Italy, which have a high GDP per capita as well as a similar healthcare systems. Again, both countries had R values that initially were elevated, but have since decreased to below the critical value of 1, and they both did so roughly around day 60. However, the spread of the virus in Italy was initially much higher compared to Spain. One explanation for this is that Italy was simply conducting more tests. And this was certainly true if we look at the total tests conducted until recently in late April. But this may also be a product of the fact that the virus was spreading so quickly in Italy, which triggered more testing. Unfortunately, we were not able to compare testing earlier in the pandemic due to the lack of data from these two countries. The initial difference also cannot be adequately explained by the timing of their social distancing measures, because we see that Italy had approximately the same measures as Spain, but conducted them even earlier, which does not explain this trend either. Looking at Canada, the US, and Australia, we see that they have comparable GDP per capita and healthcare indices. Their R values at the beginning of the pandemic were somewhat variable, and the US and Australia fluctuated significantly in the beginning. And while they all eventually brought their orders below 1, Australia was the first to win that race by 20 to 30 days. Australia also managed to maintain their reproduction number well below 1, whereas Canada and the US faltered a little bit. While Australia did conduct more tests than both countries, the difference is not great enough to explain the early control of the pandemic. However, looking at the timing of their social distancing interventions, this starts to make more sense. Canada implemented these measures 40 to 60 days after their first case, and the US did it within 50 to 75 days. Australia, on the other hand, did it earlier, around 30 to 40 days. Yet notice that Australia has not fully closed their schools, and even the United States is yet to close their borders, which may indicate to us that the social distancing measures themselves may not be the critical factor here, but rather the timing of when they are implemented. Finally, we look at South Korea, China, and South Africa. In this case, they had comparable healthcare systems, but the GDP per capita in South Korea is much higher, and this is likely due to their smaller population. Again, we see the R value fluctuated widely in all countries, but South Korea quickly decreased their reproduction number below 1 by day 47, and China did so 20 days later, although there was a small fluctuation recently. South Africa, however, remains to have an R value above 1. It is clear that South Korea has a strong testing program, both early and later in the pandemic, but it's difficult to compare due to the lack of testing data from China.
Kyrillos, it's Marion here. Just a reminder, there's a few minutes left. Thank you.
Sounds good. Yeah, we'll be finishing up soon. So South Korea started their social distancing early on because students were already on a vacation and they were instructed not to return to school. Later on, they also declared a stay-at-home order, but they never shut down their businesses and they never fully closed their borders. China here and South Africa also implemented some social distancing measures early on since their first case. And it is possible that the effect of these measures in South Africa is yet to be seen, given that it has only been 2 months since their first case. So, in conclusion, governments have the power to influence the outcome of this pandemic. We saw that countries with a higher global health security index suffered a lower case fatality early on. Therefore, pandemic preparedness before an outbreak even starts can literally save lives. But after COVID-19 became a reality, most countries did follow WHO recommendations and implemented at least some social distancing measures, in addition to a variety of other initiatives. And while this is certainly necessary, these measures on their own were rarely enough, especially if they were implemented later in the pandemic. identifying those who are infected and isolating their contacts through an extensive testing program is also critical in controlling the pandemic. And yes, many of these ideas may seem intuitive or obvious, but we still saw a large variability in the timing of social distancing measures as well as in the amount of testing between countries. It is therefore our hope that presenting this data displays the importance of these factors to encourage better response in the future. Thank you.
Thank you, Om, Enrico, and Kyrillos for a fascinating presentation. Everyone, be sure to submit your questions in the chat section. So just a first question back to the countries that you used in your study. As you know, many of our participants are from Latin America. And there's a question from one of them about our decision not to include Latin America. Could you?
I think you are breaking up, so I don't know, is it just me? Sorry.
Let me try that again, Om. As you know, there's many participants listening who are from Latin America, and curious about your decision around what countries to include in your study. Just wondering if you could talk a little bit about how you made the decision to not include countries from Latin America. I know one of them was language. Was there anything else you were looking at?
Yeah, Enrico, do you want to take on that? Why we not included the?
Yeah, so we definitely agree it would have been very useful to have had countries from Latin America as well. Ultimately, the language barrier was a big factor for us because time constraint was another big factor here. So we figured that to have to translate the entirety of the websites would have been difficult because at least with, like for example, my cursory knowledge of Italian, I could at least navigate their government websites to where I needed to go, and then I could translate whatever I was missing from there. However, we just felt that it was going to be a little bit too difficult to have to start from scratch. For example, Brazil, who we saw had quite a few cases, I think it was around 80,000, but without any knowledge of Portuguese, we just kind of figured it would have been a little bit difficult. However, for future studies, that was something that we were looking at, was then taking a deeper dive into South and Central American countries.
Great, thanks so much for that. Another question just around the theme of countries that were not included. You indicate that you don't have data from South Asian countries. And at the same time, recent data suggests that the impact of the coronavirus is less than what many would have expected in South Asian countries, in particular India, with a population of over 1.3 billion. Now, you haven't presented data from South Asian countries, but why do you think this could have been, that the impact of the coronavirus is less than what many would have expected? Is there anything to worry about there, or is there anything more about the data that you might be able to conjecture on for that particular area?
Yeah, thank you, Madam. Let me take that one. Myself, coming from the South Asian countries, I think you are right. India has a huge population, 1.3 billion population, and there are in South Asia you have got 8 different countries: Pakistan, Bangladesh, Afghanistan, Nepal, Maldives, and the number of cases in these countries are initially much lower. And we know that the COVID-19 is uniquely tough enemy, and many countries have adopted different measures where some are still trying to figure it out. And that's definitely the case in many South Asian countries as well. If you look at the Czech Republic, they did it with effective use of masks. China with the isolation, very strict isolation in one province. Germany and South Korea did with the rigorous testing, tracing, and isolation as well. And Hong Kong has definitely a previous experience, which they learned, which they try to make better use of that as well. In India, initially, although they closed down, they restricted the flight, as you saw Enrico mentioned that they restricted the flight from certain regions, from Italy, from China, but the testing was a big issue. But when you look at last 3 days, or even if you look at last 1 week, the number is certainly increasing in India. They have got around 50,000 cases, but just in the last 3 days, they have added 10,000 cases. So the mortality is around 1,700 in India only. In Nepal, they are slightly increasing around 80. Same is with the Pakistan as well. So I think the number is going to go up, but it is just because they had very few testing as well, and there was issues with the testing. What test are you going to use? They didn't have the capacity to use the RT-PCR, which is used for the initial phase, and many are using the RDT, the rapid diagnostic test as well. So I think there is an issue of the resources they were available in these countries at that period. So that could have affected, it could have influenced the result, there.
Okay. People are asking questions about which countries were included in your study and which interventions were included in your study. And clearly it's a sign of a good study when people are saying, oh, why didn't you look at this? Why didn't you look at that? So you're on the right track. So just some curiosities around what was or wasn't included. So as an example, you mentioned the public use of masks in different countries.
Yeah.
First of all, would it be possible to investigate public use of masks in each country and or the recommendations by various countries for the public to use masks? Is that something that would be a valuable addition to your study? Is it possible to study? Can you comment a little bit on that whole area of the public use of masks and the research involved in that?
Yeah, I think let me take that one as well. If you look in this, most of the Asian countries, mainly China, in Nepal, and certain part of India, particularly in the urban areas, one of the major reasons these countries has been using masks, but for different reasons, mainly for the air pollution. But there has been some mixed messaging as well from the WHO, what type of mask is effective, which is not effective. But I think it would be, as you said, it would be a good addition to our study, and more people, what I have found is it is getting becoming more acceptable. Initially, the reason why they didn't ask individuals to use the mask, that is the surgical mask, because there wasn't enough. So to protect that from the healthcare, so that healthcare workers have enough masks. And nowadays there are in India, if you look, there are homemade masks using the paper cloth, the clothes, and as well, and cotton clothes. But I think probably it would be my understanding, although there is not much study, it depends whether you are wearing the mask to protect yourself or you are wearing the mask to protect others. I think it would be good if everyone are wearing masks. There is less likely, you'll reduce the infection. Even if you reduce it by 10%, I think that's also even a good as well. As we know, they won't protect 100%. None of the masks, unless even the N95, which has been recommended, I don't know what is the efficacy of the design as well. So I think there is a big need. McMaster University is doing testing on different type of mask as well, and I think it would be a good addition to look into our research, and definitely we'll think of that as well among our groups.
Thanks so much for that, Om. Another question again around the countries included in your study and the implications for your results. And we know that language was a barrier and time constraints with the study and so on. But countries such as Taiwan and Vietnam have been successful in controlling the virus, more so than other countries. Could you comment a little bit about that? I know it's not in your research study, and of course you do have limitations on that, but could you comment at all on Taiwan and Vietnam?
Yeah, I think if you look at Taiwan and Vietnam, they did very well. But there has been, I mean, when we look at the language, the way we included two of our members, the April, I think, who is listening there, and Shenzhen as well, they speak Chinese. So it was possible to include the dialect is similar. But there has been, the other factor was the availability of data as well. And even in China, the data was, I mean, we were not 100% sure about the accuracy or the data because there has been a lot of news going on. So we wanted to, one of the other factors was looking at the quality of the data as well. If we have got enough information, so if the data is not good enough, and probably with all the inference we draw from them might not be that appropriate as well. But I think this is a very, very valid point, and everyone, and thanks for raising that. And we will think of whether we can include some other countries like Vietnam, and they have been very successful. Thailand has been successful as well. I mean, Vietnam is very, very successful for testing. There have been some issues with the WHO, the way it is in geography as well. It is part of like the China, Republic of China, and there has been some political issues as well. So we had a very limited time, and probably having some more sub-Saharan African countries as well, and as you said, Latin American countries, the South American countries. I think we will think of that and how long. And the other thing you need to look, the four are the medical students, so they had a limited time as well. They had to attend the class, so and I've been working with them. We try to be as flexible as possible during the evening, late evening, and other. But I think probably they are very, very helpful and useful comment, and we'll consider that as well.
Thank you so much. Clearly, you're onto something here because the questions continue. You'd mentioned about the politics involved in data collection and the validity of data from certain countries. There are a lot of students that are online doing global research. Could you comment a little bit about how you and your team made decisions about the validity of data coming from various countries, understanding that there's so much politics involved in releasing data? Could you talk a little bit about that, please?
Thank you very much. I think we had a big discussion, couple of the webinar and the online among our groups. And I'll just let Kyrillos to comment on a little bit on that. Then I'll add something as well. Kyrillos, do you want to take a little bit on that?
Absolutely. So I'm not sure. Is the sound okay? You guys can hear me?
Yeah, you sound terrific. Thanks. Yeah.
Yeah. So So to answer that question, that's absolutely true, and it is definitely something we took into account. When we were initially collecting data, we made sure to look at official news sources that we decided were reliable, and that was not necessarily that didn't necessarily need to come from the country we were looking at. For example, we were able to get news about China in the Guardian, or we were able to get news about other countries from CBC Canada. So we deemed certain sources to be reliable sources of information, and we used them appropriately. That was one factor that we considered. The other thing is when we collected the data at the end and we were looking at sort of the trends that we were seeing, certain things just sometimes did not make sense, and sometimes certain trends were known, in the global community not to have been valid. One example of that was Iran. When we looked at the reported cases in Iran, they actually reported that their first case was around February 19th. And we didn't believe that this was an accurate estimate of how the COVID-19 pandemic started over there, because I just don't know how your first day you would suddenly have 22 cases. So we decided to omit the case data from countries that we felt were not being as transparent with their reporting, and Iran was just one example of that.
I mean, just adding a little bit on that, we also compared, like Johns Hopkins was one of the major. We looked at Oxford University, and there were other data as well. We tried to figure out whether there was consistency in the different database as well. So initially we looked at, and countrywide as well, the reporting from the countrywide, we did look into that data.
Okay, thank you for that. That's a very helpful response in a tricky question. This one will be our last question, and it focuses on the Canadian healthcare system, but I think it's something that could be generalized to worldwide. Do you know the difference between the Canadian health system capacity and the peak of the curve? Is that something that you'd be familiar with from your research, or is that something that would be important to look at in other countries? And the reason being, this questioner wants to know, is there a gap, and should we open up our society to the point where the peak merely matches the capacity to mitigate the other social and economic impacts? So let me just repeat that again. So you know the difference between the health system capacity and the peak of the curve. If there's a gap, should we open up our society to the point where the peak nearly matches the capacity?
Yeah, I mean, can I request Enrico to come in there a little bit, and then probably Enrico?
So it's an interesting question, and there's a million and one different ways I think that people theorize we can deal with this. For example, in the United States, they just, in some places, opened up so that they can keep their economy going without any kind of regard for the curve. And then in some parts of Canada, it's a bit more conservative, where kind of saving lives is the primary goal. So I think it's all about striking a balance between economic gains and public health concerns. So if what we were saying before holds true about if we stay under capacity, we kind of can prevent unnecessary deaths, then it would make sense that by opening the economy to just titrate it the right amount, that you could keep the economy going as much as possible while preserving life. However, that's not something that I specifically looked into, and I would have to get back to you on that exactly to see how that might impact public health.
Yep. Thanks, Enrico. Anything more to add there, Om, or can we start to wrap up?
No, I think that's a fair point, and many countries have already, while trying to open up their border, they did try to keep a space between that, whether they can handle it. I mean, there have been question about the second peak as well. So the opening so soon might, whether they will damage all the gain they have done in the first phase. So there have been a lot of cost and the benefit analysis as well. So I think probably it is not very clear as which will make sense whether to open. No, I think it is very difficult to say whether to open completely or open the border maybe only partially. So I think it is still ongoing. So very difficult at this stage.
Mm-hmm. Yes, as it has been for the whole pandemic, hard to predict. Yeah. Thank you so much, everyone, for those fascinating questions, and we hope the exchange was valuable to expanding your understanding of flattening the curve. I want to say a special thanks to our speakers, Dr. Kurmi, Enrico, and Kyrillos, for your excellent presentations and responses to the questions. We really appreciate your distinctive contributions to the webinar series. And I also want to thank all of the participants for attending today's session. We look forward to hosting the 7th webinar entitled Forecasting and Modeling. This will be held on Friday, May the 8th from 12 to 1 noon Eastern Daylight Time. And again, note, the time change is different from the first 5 webinars, so these are all at 12 noon. The next webinar features Dr. Jonathan Dushoff, Professor Biology at the Institute for Infectious Disease Research at McMaster University, and Sheena Giuliani, a research assistant at the Lamont Primary Healthcare Center at the University of Ottawa, our nation's capital. In this webinar, you'll learn more about how the tools used in forecasting and modeling can be most effective with pandemics such as COVID-19. If you haven't registered for Webinar 7 or for other webinars in the series yet, please register through the link on the website globalhealth.mcmaster.ca/2020 webinar series. So enjoy the rest of your afternoon, everyone. We look forward to your participation in our next exciting webinar. Thank you. Merci. Gracias. And danke wel.
Thank you.